It's a singular honor for me this morning to welcome you to the third annual Symposium of the Walter Sisulu Pediatric Cardiac Center for Africa. A special word of welcome to our invited guests from different parts of the world. But I want this symposium to have a real tangible buzz. I want everyone to participate, to ask questions. We have a wonderful group of talented individuals who can give us expert advice. So I would really appreciate if you all got involved and tackled the various topics which we are going to present, and hopefully at the end of this come out with some form of consensus. But this is your chance and it's your meeting, and we want you to take part in it as much as possible.
I'm talking about isolated right subclavian artery. This is an uncommon abnormality of the aortic arch, which was first described by Ghosn in the year 1908. But it was in 1964 that Stewart and his colleagues introduced the term isolation. By isolation, what they meant was a condition in which the subclavian artery, one subclavian artery, loses its connection to the aorta and becomes connected to the ipsilateral pulmonary artery by either a patent or non-patent ductus. Since Ghosn's original report, just about 100 cases or less have been reported in the literature. We recently encountered a patient with an isolated right subclavian artery. The patient is a 5-year-old weighing 13.4 kilos, mentally subnormal, who was referred for cardiological investigation on account of an incidentally discovered machinery murmur on the right side. When he was seen, on examination, the right arm was definitely smaller than the left. The difference in mid-arm circumference was about 1.5 centimeters. The right radial pulse was also weaker than the left one, and the difference in the blood pressure between the two limbs was about 25 millimeters of mercury mean pressure. He also had this continuous parasternal murmur on the right side. The echo showed continuous flow into the right pulmonary artery, but there were no intracardiac defects. And so the child was submitted to a cardiac cath and a CT angio. I hope you can see that the left hand is bigger than the right on this one. It doesn't look that obvious, but when you see the patient, it's striking. Now, the angio, the cardiac cath showed, first of all, that the patient had a left-sided aortic arch. The first branch from the aortic arch was not the innominate. It was the right common carotid. This was followed by the left common carotid and then the left subclavian. The right subclavian could not be visualized on the cath. But on late films, you could see the right subclavian filling in retrograde fashion from the right vertebral artery with flow going down into the pulmonary arteries. Now, these images were taken from the chest CT. The image on your left is an AP projection of the chest CT. That shows the right vertebral artery. And that is the right subclavian artery connected to the right pulmonary artery there. And as I said earlier, retrograde flow could be demonstrated from the right vertebral artery going down into the subclavian and then into the pulmonary artery. Now, the image on the right is a 3D reconstruction which shows the isolated subclavian artery there connected to the right pulmonary artery. So our working diagnosis for this patient was a right subclavian artery isolation with a pulmonary steal. Now, this was a bit unusual because when we looked at the literature later on, we found this condition commonly occurs with intracardiac defects, the most common of them being the tetralogy or a ventricular septal defect. Now, the ductus which connects the subclavian artery to the pulmonary artery may either be patent or non-patent, or there are instances where bilateral ductuses have been described. The left side is affected more frequently than the right. One paper we saw quoted an incidence of 0.08% of right aortic arches for a left isolated subclavian artery. But this patient had a right subclavian artery isolation, which was in isolation. There were no intracardiac defects. The patient was submitted to surgery. Median stenotomy was performed. Pericardium was opened. And what you see on the arrow there is the ascending aorta, which has been retracted to the left. The head end is up there. That's the head end of the patient. The feet end are down there. So that's the ascending aorta there. And on that side, you see the SVC. And between them is the pulmonary artery, to which is connected the isolated vessel there, which you had a loop. The loop was around it there. Now, the decision was whether to just ligate this vessel or to reimplant it. This image shows you the blood pressure recording intra-op. We had 2 catheters in both radial arteries to measure the blood pressure. The recording in the red on the left-hand side there shows you the left radial artery. This was just after induction, which showed a mean pressure of 60. The mean pressure on the right was 35, so there was a pressure difference of 25. Now, this is the image you see on the right is what was obtained when the vessel was clamped. You see the mean pressure on the left radial artery there, 95, and that on the right was 86. So the difference there had reduced from here, which was 25, to 9. And so based on that, we thought it was proper to just ligate the vessel and not reimplant it. So that is what was done for this patient. He was discharged, made uneventful recovery, and remains well up till today. And this is just an attempt to illustrate the embryology, which is explained on the basis of Edwards' hypothetical double arch system. The image you see on the right, you have the dorsal aorta in red, the ventral aorta is in green, and the arches are in yellow. What you see on the right-hand side here is attempting to show what happens before you get an isolated right subclavian artery. Here you get involution of the dorsal aorta, the right fourth arch and dorsal aorta between the fourth and sixth arches, and the dorsal aorta distal to the seventh intersegmental artery. Seventh intersegmental artery gives rise to the subclavian, together with retention of the right sixth arch, which persists as the ductus arteriosus and connects the subclavian artery to the pulmonary artery. So in summary, this is a patient who presented with unequal limb pulses. All other peripheral pulses were normal. And we want to say here that if you have a patient with this kind of presentation, you should suspect that there might be an isolation of the subclavian artery. Subclavian or pulmonary steal phenomenon may occur based on ductal patency and the pulmonary artery pressure. The diagnosis is based on high index of suspicion. What may help you make a diagnosis? The echo, the cath, the chest CT. Some people use MRI as well. Treatment options involve either ligation or reimplantation. In this patient, we chose to ligate the vessel.